some childhood renal disorders. Your objectives are upon completion of this presentation, you will be able to apply the pathophysiology, the etiology, clinical features, diagnostics, and management of acute kidney injury to patient care. Also, the pathophysiology of nephrotic syndrome to patient care, and then the pathophysiology and symptoms of acute glomerular nephritis to the care of patients diagnosed with this diseases. And also, then we're going to apply the nursing process to the administration of the medications that we treat all of these different disorders with. And as you'll see, there are a lot of the same medications. So, kidney disorders in children, their kidneys become damaged and they're not able to filter blood, can lead to other medical problems, particularly acute kidney injury is that sudden decrease in kidney function. Chronic kidney disease is that long period of decrease in kidney function over a longer period of time. Chronic kidney disease and renal disorders are more common in adults than in children, but it does occur. Sometimes it can lead to behavior problems for kids, emotional distress, low self esteem. So we have that psychosocial aspect of those diseases. Some of the complications of kidney disorders, these children can become anemic, they can develop cardiovascular disease, electrolyte imbalances, they can develop hypertension, then they can have delayed growth episodes and develop growth problems. Sometimes some metabolic acidosis occurs, and then mineral and bone disorders, depending on what age they develop this kidney disorder or experience it, that could hinder their bone growth. Can lead to infections, cognitive disorders, and then urinary incontinence, which again is going to play back into that psychosocial aspect for these children. So we really need to kind of monitor that as best we can. Um, Talking about acute glomerular nephritis, it is a benign inflammation of the glomeruli, which is inside the kidney itself. Typically, it follows streptococcal glomerular nephritis infection, and that's with the group A beta streptococcal infections. We commonly see this disorder in school age children, so they're a little bit older when we see or they get diagnosed with that acute glomerular nephritis. The hallmark signs for that is oliguria. These children start to swell and then they'll develop hematuria, and that swelling could be generalized all over their body. We see hypertension, circulatory congestion, and then proteinuria. So it is a benign inflammation. It can last about 1 to 2 weeks in these kids, and they can become pretty sick as well. And then if it follows that streptococcal infection, they might have that infection on top of it as well. So leads to a lot of different disorders for these kids. When we talk about risk factors for that acute glomerular nephritis, it is that post streptococcal glomerular nephritis, recent upper respiratory infections, or they've had some type of streptococcal infection somewhere in their body. Signs and symptoms. Some of the hallmark signs and symptoms are that cloudy tea-colored urine or it's real dark. They have decreased urine output and they get periorbital swelling as well. They can develop some anorexia, some irritability. Okay, they're telling me try share the slides. Let me see if it works. Sorry. Can y'all see those now? No, you cannot. Can y'all see my slides?
Yes. Yeah, it
Yes?
was just on. Yeah. Yes.
You can see them?
Yes.
Yay! Thank you. All right. Let's get to where we need to be. So the hallmark signs and symptoms are that periorbital swelling, which is very uncommon in kids, right? The cloudy tea-colored urine, and then they're going to have a decreased urine output. Their blood pressure is going to be elevated, and we don't typically see that in children. And then they also get that facial edema that is worse in the morning. I kind of look at that as they're laying down all night, and then when they wake up, that swelling is there, so we tend to notice it. They're pretty irritable. When we do urine samples, we see proteinuria and hematuria. They may or may not have a low grade temperature, so they're really not feverish. So they're not going to really show signs of a fever. They may have some vomiting. And then if the symptoms worsen, they can develop encephalopathy that can lead to seizures. We also see genitalia and gonadal swelling as well. So it's just generalized swelling all over the body. Some diagnostics for acute glomerular nephritis, we do a throat culture and we're going to identify that streptococcal infection. A urinalysis is going to show that proteinuria, the hematuria, and then the color is going to be that tea colored or Coca-Cola colored, they call it. You may see some hematuria in it, and then the specific gravity is going to increase. Your serum kidney functions, your BUN and creatinine are going to be elevated. Your CBC may or may not show any changes in the WBCs. You may see some WBCs in the serum, but you may also see a low H&H. Your erythrocyte sedimentation rate, your ESR, is going to be elevated. The anti-streptolysin O, the ASO titer, is going to be positive. And that what that titer indicates is that this patient has had a streptococcal infection at some point. Blood component 3, C3, is going to be increased. And we typically see this increased in the recovery phase. So you may not see it elevated until about 10 to 14 days post signs and symptoms of the infection starting. Kidney biopsy is going to be a hallmark biopsy to identify the organism, but they don't always go straight to a kidney biopsy. They're going to try treatment first because think about it, a kidney biopsy in a kid is pretty invasive. Chest x-ray, we look at a chest x-ray for that enlarged heart or fluid. We can also see pleural effusions, and then that pulmonary congestion may be evident on that chest x-ray. Medication management, obviously diuretics because they're fluid overload, and antihypertensives because they have high blood pressure. These patients may or may not be on those high blood pressure medicines post infection, depends on how well they can stabilize that blood pressure. The diuretics we use to get rid of that extra fluid. The antihypertensives we use to bring that blood pressure back to normal. So we definitely want to, as a nurse, we want to monitor that. Think about what we're going to monitor with these medications. If we're trying to get rid of fluid with the diuretics, we're going to monitor their fluids. They're probably going to be on a fluid restriction. They're definitely going to be on I's and O's. Antihypertensives, we're going to monitor their blood pressure. We're going to make sure that they're not developing any headaches. And then also keep in mind, this is pretty traumatic for a kid. So we definitely, and now they're on a lot of medications for kids who probably never took medicines but vitamins before, right? So definitely some management for the parents and the patient. Depending on the type of infection, especially the streptococcal, they're going to need antibiotics to treat that. So now we're giving this kid 3 different medications in the least, and that's a lot for a kid to handle. So think about the psychosocial aspects of it. Definitely with antibiotics, think about what we're going to educate them, take it with food, complete the entire course, even if they start to feel better. Explain some of the side effects that they may feel nauseous and they may not have a loss of appetite as well. Our phosphate binders are going to help decrease the absorption of that phosphate in the GI tract. So if it's working on the GI tract, think about they may have some increased stools. So again, education with these patients. The sodium polycystyrene sulfonate is one of the side effects is it's gonna cause constipation. So we definitely wanna, increase the fiber in their diet because we can't necessarily increase the fluids because 'cause they're already fluid overload. Um, that medication is gonna help with this get rid of the extra sodium through the GI tract. So again, we're gonna have to monitor these patients, monitor their stools, and then they're going to need their sodium levels monitored as well. Some of our nursing interventions, if they're mild symptoms, they're going to monitor them at home. If they're not mild and they're more, or they're sicker and have that fever, they're probably going to be at least in a pediatric ICU room or an intensive care unit. Eyes and nose, definitely monitor their urine output. Definitely educate the parents to make sure that they're urinating and monitoring that output. Give them a urinal to take home and then monitor and measure that urine. And they should probably keep track of it. So, a lot of that is education on our part. Weigh the patient daily, monitor their vital signs, and then we definitely want them to get adequate nutritional intake and limit that sodium intake. Assist with activities and monitor for fatigue because they can become very fatigued as well. Think about it, if the kidneys aren't getting rid of all of the toxins, that's going to weigh them down and make them feel fatigued and tired. Give them age appropriate diversional activities and then just try to keep them from infections or around people who have infections. Definitely want to educate the mom to monitor that urine output for the color, the consistency, and then the amount as well. Psychosocial management, again, trying to get this child to talk about their feelings, especially related to their disturbed body image. And they're going to have that disturbed body image because of that severe swelling. Encourage those dietary restrictions, sodium restrictions, and think about it. What does a school age kid eat all the time? Fast food, right? And think about the amount of sodium in it, or pizza and the types of foods that they eat. Encourage adequate rest, which good luck with that one, right? A school age kid. But they may feel so weak and tired that they'll comply with that. Educate the importance of the follow-up appointments. That's really more so for the parents because they're obviously going to have to take them. And then educate them on staying away from sick people or crowds and doing that good hand hygiene to prevent infection. Any questions on acute glomerulonephritis? We're all good? Yes, we're good, or yes, you have a question. Yes, we're good? All right. So let's talk about nephrotic syndrome. This is alterations in that glomerular membrane. And remember that membrane allows those proteins, particularly albumin, to pass into the urine to then be excreted. It's going to result, the nephrotic syndrome is going to result in decreased blood osmotic pressure. And then it's going to lead to proteinuria, hyperlipidemia, hypoalbuminemia, and then edema in the patient. It's classified according to the amount of the membrane destruction. I don't think NCLEX will test you on like the particulars of this, but I do think that you need to be aware that, again, it does classify according to the amount of membrane destruction. So the minimal change nephrotic syndrome is your most mild, and it is the most common. The focal glomerular sclerosis and the membranoproliferative is some of your more serious ones. There are 3 types. The primary, which directly results in glomerular injury. The secondary, which occurs related to or secondary to a systemic illness. And then congenital is obviously those inherited disorders of nephrotic syndrome. Our risk factors, these children are a little younger, your preschool age children. Unknown cause, there are multifactorial etiology. It could be metabolic, it could be biochemical, it could be physiochemical, and all 3 cause disturbances in the basement membrane of that glomeruli. So it's actual to the glomeruli inside the kidney. Your signs and symptoms, these patients are going to gain a large amount of weight in a short period of time, typically days or weeks. Again, that facial swelling, periorbital swelling. They're going to have ascites, which can in turn cause dyspnea, edema in their lower extremities, swelling of the genitalia. The Merckney lines on the fingernails, if you take a look at that picture, I couldn't find them in kids, but that's an adult. But those are I think they're pronounced Merckney lines on those fingernails, are the white lines that are linear, and they are parallel to that luna, which is that white part on the nail bed closest to the fingers. These patients are going to be pale in color, have some anorexia, irritability, and when they pee, that urine is going to be frothy, and dark. And again, you're going to see a decreased urine output. So when we look at labs, if with that decreased urine output, we're going to have an increased BUN and particularly the creatinine level, right? Their blood pressure in patients with nephrotic syndrome is typically normal or just slightly lower than normal. So they have the opposite of the hypertension. You think they would have hypertension as well with all that swelling and ascites and edema, but they have a normal blood pressure, slightly lower blood pressure. Because remember, the kidneys help with the blood pressure and regulating blood pressure as well. Some of the complications, these patients are more at risk for infection, particularly developing sepsis. And then they can be unresponsive to the steroid therapy, which is the first line therapy for these patients. It gets diagnosed with the 24-hour urine collection. They typically will see up to 15 grams of protein in the specimens, and you'll see a lot of hyaline cast and RBCs when they're looking at the concentration and color and what's in it. Also, the specific gravity of that 24-hour urine is going to be elevated. When we look at the chemistries, we're going to see elevated BUN and creatinine because, again, the kidneys aren't functioning well, right? You may see hyponatremia and you may see increased calcium levels, and then your increased SED rate, your ESR as well, because SED rate is indicative of swelling and infection. Again, we do a kidney biopsy or an MRI is going to be able to give them a good picture of the function of the kidney and what the glomerular really look like. Again, that kidney biopsy is the most invasive, so we start with the MRIs first. Some medications, like I said, corticosteroids are used. That's going to help decrease that inflammation because remember, they're steroids. Um, they typically are given high doses the first 4 to 6 weeks. So that's a long period of time, right? And then think about the side effects of those corticosteroids. They're going to have an increased appetite. They could develop facial hair. They could slow their growth, especially if they're on it for long periods of time. They can then develop hypertension, some GI upset. So, closely monitoring these patients. And then we all know corticosteroids cause hyperglycemia to add to another complication, which we really don't want, right? Some of our nursing interventions for it is we definitely want to administer it with meals because of that GI upset, and then monitor those side effects. Your diuretics, your drug of choice is furosemide, which is the Lasix to help get rid of and pull off that extra fluid. Remember, we want to encourage these patients to eat foods high in potassium and then monitor their I's and O's. Sometimes they get plasma expanders, which is your 25% albumin, and that's used to increase the plasma volume and then decrease the edema. But again, we're going to monitor the I's and O's, and we're going to, unfortunately, albumin is a medication that is frequently causes anaphylaxis. So we're definitely going to monitor and be ready. Should these patients have any of the anaphylactic signs and symptoms, that dyspnea, rash, pruritus, difficulty breathing, any of those. And then immunosuppressants. Cyclophosphamide is the drug of choice for immunosuppressants. And they'll give the immunosuppressants if the patients aren't tolerated or if they're unresponsive to that corticosteroid therapy. Definitely a dietary consult, and then provide emotional support. These kids are in school, so make sure that their school needs are being met. Maybe bring in some schoolwork, kind of give them some diversion, and then consult a nephrologist. Nursing interventions, again, try to get them to verbalize their feelings, manage their diet, definitely staying up to date on immunizations to help prevent that infection, provide adequate rest, good infection control, and then definitely monitoring their blood pressure, daily weights, and frequent urinalysis. Any questions on nephrotic syndrome? Can they have high or low protein? So they should not they should have a higher protein because they are children. Stay away from the carbs, which cause I always say carbs cause swelling. We're not going to increase their protein intake though. So let's talk about acute kidney injury. This occurs because the kidneys are not able to excrete the waste. They're not able to excrete the materials that require filtering. They're not able to concentrate the urine, and they're not able to conserve those electrolytes. And what are some of the risk factors? Well, there's several different types. It could be pre-renal, it could be intrinsic renal, or it could be post-renal. Your pre-renal conditions are going to be your dehydration, diabetes, surgical shock, trauma, accidental poisoning by, illicit drugs, or just poisoning if they've taken too much of a drug, or those medications um, that are excreted through the kidneys or the urine via the kidneys that is in toxic levels. Or prolonged anesthesia can cause acute kidney injury. Your intrinsic renal factors, nephrotic or nephrotoxic medications, which are, remember, are gentamicin, vancomycin, a lot of the medications we talked about the other day as far as our anti-infectives and antibiotics. Hemolytic uremic syndrome, acute glomerulonephritis can cause acute kidney injury, and then ischemia to those kidneys, lack of blood flow to a part of the kidney or one of the kidneys. Post-renal is going to be your kidney stones or your tumors. So think about those things that are outside of the kidney itself. Signs and symptoms
Can you
that
go back?
oliguria.
Can you go back a
Yes.
little bit?
This one.
Yes,
Go back
that
to
one.
this one?
Yes.
Okay. Did you have a question? Did you have a question on this?
No, I was just writing something down. You can go ahead now.
So that oliguria is defined as urine output less than 1 ml per kilogram per hour. So think about if these patients are school age and preschool age, if they're weighing 50, 60 pounds, that's less than 30 mLs per hour. Sometimes they're going to have an abrupt diuresis. They're going to just expel a lot of urine. They can have edema, drowsiness, circulatory collapse, and then they can develop some cardiac arrhythmias, especially because of that hyperkalemia. They can develop seizures from the hyponatremia or the hypocalcemia, and then tachypnea because of the metabolic acidosis that occurs. They may have some CNS manifestations from that continued oliguria and develop become very drowsy and often altered mental status. So our lab findings, again, you see we're doing a lot of the same labs, right? Because with any kidney problem, these patients are at risk for anemia, metabolic acidosis, and then kidney disruption with that elevated BUN and creatinine. So our serum electrolytes are going to reveal that hyperkalemia, the hyponatremia, and the hypercalcemia. Their urine creatinine clearance is going to be decreased. The glomerular filtration rate is going to be decreased. That ABG is probably going to show that metabolic acidosis. Your H&H is going to reveal anemia, so it's going to be lowered. Your serum creatinine and BUN are going to be elevated. That EKG can show some arrhythmias due to the potassium and electrolyte imbalances. And then we can do an intravenous pilogram, the IVP, where they actually inject dye, and then you can see that's a picture there where it actually lights up, and they can see whether those kidneys are functioning or what's going on. Is there a blockage? Where the problem is. Again, that's a contrast. So remember, contrast dye is one of the major things that people, or one of the most common causes of an allergic reaction, and it does contain iodine. that contrast. So we definitely need to be assessing for those allergies. And then an MRI as well can reveal any structural damage to the kidneys. Complications of that acute kidney injury, the same as we've seen in the other two disorders, right? Infection, anemia, fluid overload, hypernatremia. And then what types of medications do you think we treat them with? Well, furosemide, diuretics, getting that fluid off, right? Your calcium gluconate is going to reduce the potassium level. Your sodium bicarb is going to help with that blood pH, and giving it causes a transient fluid shift. Your glucose and insulin helps with that hyperkalemia to decrease that potassium level. And then this sodium polystyrene sulfonate we talked about a few minutes ago, that is an oral or a rectal preparation, and it's going to bind with that potassium to excrete it through the GI tract. Your antihypertensives, if they're very hypertensive, they're going to get labetalol or nitrous presside IV, or nitroprusside IV. Hydroxyline, clonidine, and verapamil are, and also captopril are your PO. So if they're not as hypertensive and they don't require that IV or that quicker medication, they'll get the pill. And then propanolol and nifedamine, they may go home on those just to keep the blood pressure at bay for a little while once they've gotten over that acute kidney injury. They may require dialysis depending on what the cause was. Especially, I've seen it with overdose patients, depending on what they find in their system. It could cause rhabdomyolysis, or it could cause complete kidney, acute kidney injury, and they may need dialysis to get rid of those toxins. They may also require hemofiltration, again, to get rid of those toxins and those waste products. Nutrition management, we want to prevent that fluid overload, especially if these patients are on TPN, depending on what caused that kidney injury. If it's a trauma patient or a burn patient, think about that acute kidney injury that results from that trauma or that burn. So they may be suffering from, or maybe very serious trauma or burn, but they've also developed acute kidney injury and they may be on TPN to help the burn or the trauma. So we definitely want to prevent that fluid overload. High calories that are going to decrease that tissue catabolism, and then decrease fluid intake with foods so that they can get the nutrients and also that fluid restriction as well. Education, we want to give them adequate rest, adhere to medication management, and then adhere to their follow-up appointments and monitor their urine output. I've seen lots of, not lots of, but multiple times older patients who have been on antibiotics that have caused renal failure, being acute kidney injury, and also those younger patients, whether it be an accidental or an intentional or just an overdose, they wind up with acute kidney injury because of the medications. Sometimes they need dialysis to excrete that and get rid of that toxin right away to get those kidneys functioning again. So our nursing interventions, again, going to focus on that fluid overload and monitoring those I's and O's, assessing and managing that underlying cause, like I was talking about, if it's trauma or a burn or if it's the toxins. Most often these patients are in ICU at least for the first 24, 48 hours. They're going to have a limited or decreased fluid intake. Definitely going to weigh them daily to make sure that we're getting ahead of any of those slight changes. And then sometimes it becomes a fine balance between that fluids and electrolytes. We don't want to give them too much fluids, but we need to maintain their electrolytes as well. So sometimes it's a catch up and a game that we're playing. Definitely want to try and keep their body temperature normal, not too hot, not too cold. Limit their activity, encourage rest. Assess their neurostatus frequently to detect any of those changes that they could be developing, that early encephalopathy. And then monitor their temperature and provide support for the family and the patient as well, right? Any questions? That was a quick no. So I have some practice questions. The beautiful thing about learning is that no one can take it away from you. So I'm sorry we had the little mix up in the beginning, but that was down and dirty and quick. Did you have a question?
Yes, Professor. So I was wondering when you said they need TPN for feeding. Why would they need TPN?
So not for necessarily for the acute kidney injury, but if it's something that caused that remember, acute kidney injury can be caused by a trauma or a burn. So a lot of times those patients require TPN because of the trauma or the burn. They're, depending on how badly they're burned or how badly they're injured, they may not be able to eat, but they need nutrients. So they're on TPN. But that trauma or that burn caused that acute kidney injury. So they don't necessarily need the TPN for the acute kidney injury, but they need it for the underlying cause. Does that make sense?
Thank you. Yes, thank you.
Any other questions? All right, let's do some practice questions. So this is one of those questions where they're going to give...
I'm so sorry. Professor?
Yes.
Please, I didn't get the cause of nephrotic syndrome. I didn't get the causes. Please, can you repeat what causes it?
I'm having a hard time hearing you. There's some background noise. What?
Let me leave where I have maybe. I just want to know the cause of the nephrotic syndrome. Can you hear me, ma?
Okay, that's a little better.
Okay. I didn't get the causes.
You didn't get what? I'm sorry.
I said I didn't get the causes of the nephrotic syndrome.
You didn't get the what for the nephrotic syndrome?
Yes. The causes.
Oh, the causes. So risk factors. They could be metabolic, biochemical, or physiochemical. All of them are going to cause a disturbance in that glomeruli. They typically occur in school-age children, and again, we don't really have a known cause for them.
Oh. Thank you, ma'am.
You're welcome. Yes.
So does a hospice patient really need TPN? Someone who is in hospice?
In hospice?
Yes.
So it depends on what they're in hospice for. Typically, if they're in hospice, they're not going to do heroic measures. So, they may or may not be on TPN. It depends on what's going on. I don't know. That's a hard question to answer because typically hospice doesn't do life-saving measures, but if that's not why they're in hospice, then they may be on TPN. That's not a like yes or no question to be answered because say somebody has esophageal cancer and they obviously can't eat very well, right? So they may be on TPN, but they may not be close to dying, but they're getting but they're getting TPN at home or they're in the hospice unit getting TPN because they can't eat, but that's kind of is there a reference for why you were asking that?
So I saw a question on that on an NCLEX question saying a
Okay.
patient is on hospice and they were asking if the patient really need TPN. So I was wondering, like, we know that, we are supposed to care for them, make them comfortable, but do we have to deprive them from food? And also, I was saying, do they really need the TPN? So I'm confused.
I would have to look at the question to see. So like in the instance that I was um so I'll give you an example. My mom had colon cancer and she put herself on hospice like 6 months before she died. Um because she said she wasn't going to do any more chemo. There was nothing that could be done. She had colon cancer. So she prior to that she was still healthy. She fell and broke her hip. She fell in the
Oh,
house and because the chemo made her bones brittle, she was only 49 years old when she got diagnosed. So she wasn't like right at the time of dying, but she needed her hip fixed. So she had the surgery, they fixed her hip, but she was not able to eat because of the chemo and all of that. So they gave her TPN for a short period of time. So I would have to look at the question.
okay.
Like being on hospice itself doesn't it just depends. It depends on what they're on hospice for. So like somebody who has esophageal cancer or throat cancer or mouth cancer, they may not be able to eat, so they may be on TPN but they're not dying yet from the mouth cancer or the throat cancer. Does that make sense?
Right, right.
I
Yeah.
would have to look at the question. I don't think yeah, I would have to look at the specific question because that's a hard one. Unfortunately, students want to know it's all or nothing, and there's sometimes not all or nothing answers. You don't see the screen because I took it off the screen watching the questions right now because people were asking questions. I'll put it back in just a minute. Does anybody else have any questions? Just if you get a question like that, kind of rationalize through it and use critical thinking. What do you think is the best answer? right? Like, we're still going to give somebody pain medication if they're on hospice. We're still going to give them fluids and, food up until the time that they're ready to die, unfortunately. So like you'd have to weigh what else is going on with that patient.
Right. Thank you for the clarification.
All right. So let's look at our question. This is one of those questions that's going to give you a part of a patient's chart, and then it's going to ask either 4 to 6 questions. So it's kind of a case scenario. NCLEX will do this, and then the questions are all going to be something related to the nursing process. So, the nurse in the pediatric clinic is caring for a 6-year-old male client. Your nurse's note on day 1 at 9:30 when the patient came in. Client presents with decreased urine output over the last 2 days, fatigue, and puffy eyes in the morning. The parent reports recent history of sore throat about 10 days ago. He has vomited twice in the past 24 hours. No fever reported, and he appears pale and is lying quietly on the exam table. His weight increased by 4.4 pounds, 2 kilograms, in the last 3 days, and his current weight is 57 pounds, 26 kilograms. Take a look at his vital signs. Anything abnormal there or concern you?
Yeah. Heart rate.
His heart rate's a little elevated.
The heart rate, the respiration, the
Yeah.
breathing too.
What about his blood pressure? He's 6 years old. Is that a normal blood pressure?
No, it's high.
That's a little elevated too.
It's high, yeah.
So given all those symptoms and those vital signs, what do y'all think?
Acute glomerulonephritis.
Good guess. So let's see. So again, it's your 6-year-old client. He's male. The nurse reviews the client's medical record. Which of the following findings require immediate follow-up?
Blood pressure. Puffy eyes.
Okay.
I would say blood pressure and vomiting.
Okay.
Then history of salt. No, history. No, those two. Blood pressure and vomiting.
Blood pressure and vomiting.
Yes.
And I got blood pressure and puffy eyes. Anybody else?
A, B, C, D.
The A, appearance.
A, B, C, D, somebody said?
Yes.
Okay.
A, C, and D.
Okay. So let's go through these and talk about them. So ask yourself, what is it? Because it's an immediate follow-up. So that means we need to do something for this patient right now, right? And what are the things that could hurt or kill or make this patient worse, right? So can puffy eyes, is that really dangerous? Or do we expect that with acute glomerulonephritis? And what are we going to do for it? There's really nothing. While it's kind of concerning, it's a symptom of fluid retention, right? So we're not really concerned with the puffy eyes. The history of a sore throat, what am I going to immediately do with that information? That's just going to help solidify the acute glomerulonephritis that we think it is, right? Lying quietly on the exam table, is that going to harm this patient? No. So A, B, and C are those things that we need to follow up immediately. Pale appearance is a circulation problem, right? That means this patient could be anemic, which could cause potential problems. If he's bleeding internally, he has poor circulation, right? Both of those require follow-up, especially in a 6-year-old child. High blood pressure definitely requires follow-up because remember, the higher the blood pressure, the less the kidneys are functioning too. And then vomiting, remember, he's 6 years old. So while if it was an adult, I might not be so concerned with vomiting, but remember, our children are a vulnerable population and they become dehydrated very quickly. So that's taken that whole patient into consideration. We're taking into the fact that he's 6 years old and what are those things that are most serious for our vulnerable population. So it's circulation in that pale appearance, blood pressure, and then vomiting. Does that make sense? Everybody see that?
Yes. But Professor,
Yes.
sometimes these answers makes us get confused because sometimes they would say like the blood pressure they would say is expected. So like it doesn't really need immediate follow up.
Well, for this child is 6 years old. So that's an elevated blood pressure for a 6-year-old. It's a
What's
higher blood pressure. So
what's the
remember,
blood?
the higher the blood pressure, the less the kidneys are functioning, right?
Right.
So
So
it is an immediate follow-up for this kid. So remember, I think of blood pressure as part of circulation too, right? So if
Yes.
he's pale, has poor circulation, plus he's vomiting, plus he's got high blood pressure, I would really expect him to have a low blood pressure, right? Either way, I would be concerned, but that's a little elevated for a 6-year-old. That means he's not getting perfusion somewhere, right? That blood pressure, that heart's trying to compensate for that lack of perfusion and that kidneys that aren't functioning correctly, right? Does that make
Right.
sense for this question? So again, you have to look at your questions and each question kind of stands alone. So blood pressure for this question is a correct answer. But you may get a question where the blood pressure is not the correct answer and we're not concerned about it, right? You have to look at the whole scenario for each one. Did that help? Hi.
yes.
Okay. So again, our 6-year-old patient, now we have a 10 o'clock nurse's note. The urinalysis is ordered. The periorbital edema and dark colored urine upon voiding in the clinic is noted. The nurse reviews the client's medical record. Which of the following conditions should the nurse recognize as the client's likely diagnosis? So again, he's going to have more than one.
I'll go for A, C, and E.
A, C, and what?
E.
E?
No.
So A and C are correct. So it's actually A, C, and D. a urinary tract infection because we can't differentiate right yet. Is it a urinary tract infection or is it the acute glomerular nephritis? More than likely, he's got that acute post-streptococcal glomerulonephritis. He's got an acute kidney injury and urinary tract infection, or it could be one of those. We're not pointing towards dehydration so much, because he still has a decent blood pressure that's higher. It's not nephrotic syndrome because these patients typically have proteinuria and not hematuria with nephrotic syndrome. And these nephrotic syndrome, they're going to have that edema, but not that elevated blood pressure. Remember, the blood pressure is more normal or lower in nephrotic syndrome. And then cryptochidism is undescended testes. And that's like a nothing diagnosis. Nothing points to that in this scenario. Does that make sense to everybody?
Yes, to me. I don't know.
All right. So our 1030 nurses notes, the BUN, creatinine, urinalysis, and ultrasound of the kidneys are ordered. Laboratory specimens have been collected as ordered. They're still awaiting the ultrasound of the kidneys. The client is tearful and asks if he is really sick. The parents appear anxious. Per the pediatrician, the client will be transferred to the pediatric unit with suspected acute glomerular nephritis. The nurse has reviewed the nurse's notes from 1030. Complete the following sentence by choosing the list of options. So on NCLEX, there will more than likely be an arrow where you drop down and choose those. Those are called drop-down questions. So the nurse should first address the client's what?
B.
I will go for B.
B.
Good. You guys are good. Yes. You want to address his emotional status, right? The pending lab results, they've been collected. You did your job, right? Now we're waiting on the lab. That may require follow-up down the road, but right now this kid's upset and he's scared. So we need to deal, and the mom or the parent is anxious. So we need to deal with that. Blood pressure, again, it was elevated, but it wasn't extremely elevated. And then his pending kidney ultrasound, again, it's been ordered, right? We got to wait on radiology. If they don't come, then we got to follow up, right? Good job. Don't forget that psychosocial with patients either. So our 1330, caregiver and client reassured and admitted to the pediatric unit. Peripheral venous access device has been inserted. His urine output of 50 mLs over the last 8 hours and orders are pending. So for each potential nursing intervention listed, specify if the intervention is indicated or not indicated for this client. So let's go through the first one. Do you think it's indicated or not indicated to offer the client a salty snack?
Not
Not
indicated.
indicated.
No, it's not indicated, right? Because we don't want salt in this patient's diet, right? Monitor intake and output, indicated or not indicated?
Yes.
Indicated.
Yep, it is. Administer IV normal saline bolus.
Not indicated.
Not indicated.
You are correct. Why not?
Indicated.
The border.
It's already
Because it's a
having
bolus.
Because of the
Yes.
fluid
The
volume
Yep,
overload.
because it's a bolus.
Yeah.
Elevate the head to bed 30 degrees.
Yes.
Yeah.
Is indicated.
Yep. So we
Indicated.
got 2 indicated and 2 not indicated. Good job.
Question. So
Yes.
if it's not a bolus, is it still indicated?
Well, It depends on what rate they would put it at. But remember, a bolus is going to go in quickly, right? And it's not giving us an amount either. So I'm a little leery with that, right? This patient may need 150 ml bolus, but without an amount, and it just says a bolus, that's going to go in real quick. If it said at 50 mLs per hour, it might be a correct answer, right? But if it's set at 150 mLs per hour, that's pretty fast, or that's a lot per hour for a 6-year-old child. So see how you gotta take the situation into effect and look at the answer choices.
Okay, thank you.
So here's our orders. At 2 o'clock, the doctor writes for furosemide 6.8 milligrams IV once, sodium restricted less than 1.5 grams per day. Weigh the patient daily and monitor electrolytes every 8 hours. So take a look at your labs. Is that BUN high or low?
Hi.
That's a high.
High.
Hi, is that?
The creatinine's high, right?
Yeah.
That urine color is yucky, right?
Okay.
That specific
That's it.
gravity is elevated. Protein and blood is up, right? And then he's got casts in his urine. So the nurse is educating student nurses on acute kidney injury. Click to indicate whether each of the following factors is a pre-renal, a renal, or a post-renal cause of acute kidney injury. So is hemorrhage pre-renal, renal, or post-renal?
Post.
So remember, post-renal is outside of the kidney. So it's going to be like your kidney stone. Well, kidney stones aren't necessarily outside, but it's caused, typically post-renal is caused by a kidney stone or a tumor.
I was
Pre-renal.
I was a renal.
Pre-renal. Your hemorrhage is pre-renal, yes. Hemolytic uremic syndrome.
Renal.
Renal.
Yep, good. Posterior urethral valves.
Renal.
Posterior.
So posterior means it's outside of the kidneys on the backside. Urethral valve. So there's like notches or narrowing of the urethra.
Post-renal then.
Post-renal. Yep.
Renal.
Post-renal. Dehydration.
Renal.
Pre-renal.
Renal.
And acute glomerulonephritis.
Renal.
Renal. Yep. There you go. There's your answers. So now at
Please
8.
show us the answers again. I need to go.
Sharp.
Thank
So
you.
remember your I look at it like this. Pre-renal is going to be your symptoms or your disease processes that cause it. The renal is going to be the actual diagnosis, I guess is how you would look at it. And then post-renal is caused by a tumor or a kidney stone or something that's blocking the urine from getting out. Make sense?
Yeah.
Yes, bro.
Jesus.
So day 2 at 8 a.m., the client voided 150 mLs overnight. Is that good or bad? Remember, he's supposed to be 1 1 ml per kilogram per hour, and he was 26 kilos.
It's a bad.
Okay. Periorbital swelling persists. The client is eating a piece of toasted bread. Weight today is 52 pounds, 24 kilograms. So he lost 2 kilograms, right? Take a look at his vital signs. Does anything concern you?
Heart rate is still high.
Yes, heart rate is high.
Temperature
Heart rate
and
for
heart
a
rate is high.
normal for a 6-year-old child.
Oh, for a 6-year-old? Oh, okay, okay.
Yeah,
Yeah.
remember he's 6.
It's
Okay.
it's 75 to 118 for a 6-year-old child.
Yeah, the temperature then is high though.
Yeah, the temperature's a little high. So the nurse reviews the client's record since admission. Which of the following findings indicate improvement in the client's condition?
The weight
Appetite.
of the patient and the blood
Blood
pressure and the
pressure.
So
weight of the
remember, so let's talk about his urine output. So remember on day 1, he had 50 mLs in 8 hours. So is 150 overnight better than 50? Because remember, we're just comparing from admission to now.
Yes,
Yes.
it's better.
Yeah,
Yep.
it's better.
Yep. His appetite was decreased, and now he's eating
It's
toast.
also better.
Yes.
Better.
Improve.
He had
improve.
periorbital swelling on
Okay.
admission, and he still has it.
Not
Not
improved.
cheap.
Not improve. Not
Right.
improve.
It's the same. His blood pressure was 122, and now it's 102.
It's
It was
Good.
122 over 88, and now it's 102 over 68.
Improved.
That's improved.
It's
Improved.
Yep.
improved.
Yep. His temperature was it was normal, and now he's 99.
Nothing.
Worsened.
Yeah. And then we already said he lost 2 kilograms. So
Not
that's
improved.
better. So if you were looking at NCLEX, you would be able to click back on the chart and take a look at those. So
Yeah, but
the
no.
answer is A, B, D, and F. Because periorbital
So-
swelling is the same, and his temperature is a little elevated.
Wait, was his weight normal in the first place, or was it too much for his age?
Say again.
His weight in the first just being admitted, was his weight normal, or was it too high for his age?
No, he had gained 4 pounds in 2 days, and he was 26 kilograms, and here he's 24. So it just wants to know. So don't worry if it's normal or not normal. They want to know if it's improved since admission. Remember, the key word on that one, on admission, he had gained 4 pounds in a couple of days. So that's not normal, right? That's all fluid.
Okay, I see where that's why I wanted to know if I can the weight improve or not improve.
So I'm only catching every other word of what you're saying. You're breaking up.
I wanted to know what it was before to know if it's improve or not improve.
Oh, okay. Yes. So he was 26 kilograms before, and now he's 24. A nurse is caring for a child with nephrotic syndrome and anasarca. Do y'all know what anasarca is?
Yes,
Fluid
generalized
overload.
edema.
Generalized edema over the whole body. Yep. Which of the following interventions should the nurse prioritize? So that means, what are you going to do first?
C.
I heard C and D.
C.
Why C?
C.
Because he has swimming, like thing.
Generalized edema, so you need to reduce the fluid.
Yep. 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 That is correct. So he's got fluid. That's his major problem. He's got a circulatory problem, right? Too much fluid overload causes the heart to work too fast and too hard, and we may not get that circulation going, right? So we need to get rid of that fluid. So the answer is C. You are correct. A nurse is educating a teenager diagnosed with nephrotic syndrome on dietary modifications. Which of the following recommendations should be included in the teaching? Again, this is a select all that apply.
C and D.
C and D. I got C, I got C, D, and E, and C and D. So it's actually C and E. We want to limit their salt intake, and then we want to get them whole grains and complex carbs. We don't want to give them a high protein, but we don't want to restrict protein either. We just want to keep the protein normal. And definitely don't want to give them a high fatty diet.
What about D?
Limited fluid intake. That's not necessarily the limited fluid intake, that's kind of vague. It doesn't say what you want to limit it to. And limited fluid intake could mean to just a particular fluid. It's kind of vague. The better answer choices are your limited salt intake and then your whole grains, because that captures what we're dealing with nephrotic syndrome.
Okay, thank you.
And so remember, go back to what's the problem and how are we going to treat it. A nurse is providing discharge education to the caregiver of a child diagnosed with nephrotic syndrome. Which of the following foods are appropriate for the client? So this wants you to apply what you know, or kind of apply what we just what we did in the previous question to this. What is it?
A and D.
A and D.
A and D.
A and D. Sausages, bacon, and canned meat all contain a lot of sodium because they're all processed, right? So your fresh fruits and your whole grains are going to be your best options. A nurse is assessing a child diagnosed with acute glomerular nephritis. Which of the following signs and symptoms should the nurse anticipate?
B.
I heard B.
B, G, D.
B, C, and E. Absolutely. That Coca-Cola, tea-colored urine, hypertension, and swelling. Polyuria, not necessarily. And then that frothy urine, we don't see that with acute glomerular nephritis. We see that with what? Nephrotic syndrome. A nurse is assessing a child whose caregiver reports recurrent sore throat infections over the past 6 months. The client is at risk of developing which of the following conditions?
Acute glomerulonephritis.
Yep, absolutely. So that is the end of my presentation. Does anybody have any questions? I'm sorry for the mix-up getting on again, but we made it through. You guys did great.
Thank you, Professor.
You are
Thank
welcome.
you.
You sound sick. Yeah. I'm trudging on. Thank you, though.
Thank you, Professor.
Thank you.
You are welcome.
Hope you feel better.
I'm good. Thank you.
Thank you, Professor. Get some rest, Professor.
Have a good night.
Have a good night.
You too. All right. If nobody has any
When next are you
questions,
coming, Professor?
do you have a question?
No, I said when next are you coming?
It's breaking up really bad. I'm sorry.
Are you coming tomorrow?
Oh, yes, I will be here tomorrow. I'm teaching neuropharmacology tomorrow night at, I think, 9 o'clock.
7 o'clock.
9 o'clock?
At
Yes.
At 7, Professor.
Oh, it's 7? Okay. It's
Okay, thank you.
You are correct. It's 7 o'clock. That's tomorrow. I got to get through today.
Oh, 7?
It threw me with the computer not working right.
Thank you, Professor.
You're welcome. You all have a good night. I'm going to say goodbye if nobody has any questions.
Bye, Professor. Good night.
Bye.
Good night.